Hello and welcome to tonight's webinar. We have an esteemed panel tonight. We have Dr. Venkat, Director and Senior Consultant at HSFC, Dr. Festrata, Sensor Apologist, Raj Joshi, Senior Embryologist. HSFC will talk about the lab perspective, about fertility options for same-sex couples, and Marion, our healthcare assistant, will talk about the counseling, and our wonderful patients, Nikoleta and Karleen, will talk about their fertility journey with us. The event will be recorded and uploaded on our website in due course. There is a Q&A question at the end. Please raise your hand or submit questions via panel. If you'd like to stay anonymous, that's fine. No need to say your name, and your camera will be off. So without further ado, I would like to hand over to Dr. Venkat, who will cover Dr. Venkat.
Good evening, ladies and gentlemen. Thank you for coming to this webinar. We will discuss all the treatments which are possible with the donor sperm for same-sex couple, and sometimes it's applicable to single women as well. Okay, so anyway, they have changed my name, Dr. Leva Vestata. I will be for a short time Dr. Leva Vestata. Anyway, so we talk about two basic treatments with the donor sperm. They have to put the sperm in the uterus or into the egg. These are the two places we can put the donor sperm to make a woman pregnant. So we put it in the uterus, that is called intrauterine insemination or artificial insemination, all same, IUI in short, these are all treatment. It is a very simple treatment, and where we place the uterus, the sperm, prepared sperm into the uterine cavity when the woman is about to ovulate. And so this can be, as I said, can be used for same-sex couples, single women. And when we have heterosexual couples, when the man doesn't have sperm and they want to use donor sperm, we can use. And also when there are some cervical factors, we can use if a woman is single or there is no partner sperm available, we can use this treatment. Next slide, please. So the requirements, that is, what are the conditions we should satisfy for someone to have intrauterine insemination? First of all, we should have plenty of sperm or good quality and quantity of sperm. There are some WHO criteria which they have to fulfill for doing the insemination. Raj will talk more in detail about this. I don't want to interfere with him. And what we do is there are two ways of doing the intrauterine insemination. We can do it on a natural cycle, particularly same-sex couple. They are not infertile women. Karleen will tell us very clearly, because they come to the clinic because they need donor sperm. And therefore, if someone is ovulating regularly in younger age group, why don't we use their naturally produced egg and put the sperm inside when she is about to ovulate? That's the right time to put the sperm in, and she is likely to get pregnant. This is called natural cycle IUI. And the other one is called stimulated or medicated cycle. What it involves is getting some tablets like clomiphene or letrozole for 5 days, not for a long time. This is to make the eggs grow in the ovaries. It can be useful in some women with mild polycystic ovaries where they don't ovulate regularly. It can be used. But sometimes we use in the same sex couple or single women, even when there is no obvious cause of infertility. This is to increase the chances of success or maximize the success rate. Because here we are paying for treatment, it's our duty to do everything to make them pregnant in the first attempt itself. That's our ethos. So that's why we say go for medicated cycle. However, we will discuss with the couple about it and discuss the risks. What is the risk? Because they can produce 2 follicles to increase the chances, and that means they can have multiple pregnancy. Obviously, if somebody produces 5 follicles, the treatment will be cancelled. However, if somebody produces 2 follicles, we will go ahead. However, there is a small risk, that is less than 10% risk of multiple pregnancy with this. If people don't mind that, we can go ahead with medicated cycle. I always tell them, look, we don't take babies back. Therefore, please, if you don't want twins, don't go for stimulated cycle. Okay, then what is the other important criteria we should look for before proceeding with the treatment? That is, they should have patent tubes. If this is the pathway between the egg and the sperm meeting, if the main road is closed, how can you go? Get out of your house. You can't. So similarly, if the fallopian tubes are blocked, the sperm and the egg cannot meet, then fertilization cannot happen. The treatment will not work. And of course, if there are other pathology like endometriosis, adenomyosis in the uterus, fibroids in the uterus, all these things can also interfere with the treatment. So we say good functioning ovary and the uterus and the presence of fallopian tubes. Then we can go for the simple treatment. But we must remember one more thing. What is the success rate? Because you are going to come to a private clinic and pay for the treatment. So you should be aware of the success rate. Success rate is good because it's a very simple treatment. Having said that, it's low compared to IVF treatment. So the success rate in a woman, say under the age of 35, up to the age of 35, it's about 10 to 15%. The national average is 12 to 13%. So if one is prepared to do that, then we can go for this treatment. And we say at least try 2 or 3 cycles, not more than that. If it hasn't worked for 3 rounds, don't waste your time and money doing this. Please move on to IVF treatment. Next slide, please. Okay, so how is IUI done? Whether it is natural cycle or medicated cycle, what we do is we ask the woman to call us on the first day of the period and book a scan on the 2nd or 3rd day of the cycle. And we make sure there are no cysts in the ovaries. That is the main criteria. If there are cysts, then it will complicate the matter. The woman may not produce ovulate normally that month, or if she's going to take medication, then it will complicate it. Therefore, we make sure there are no cysts, and then we start either natural cycle or give medications like I mentioned, clomiphene or letrozole tablets for 5 days only. And then we bring the woman back for the next scan, say on day 10 or day 11 of the cycle. By that time, if someone has got regular cycle, she should be developing a follicle. So we can see in the scan what is happening. And also at the same time, we make sure the lining is thick enough. Because in some cases, the clomiphene has got a side effect of thinning the lining of the womb or thinning the endometrium, which is against the success rate. So we don't want the lining to be thin. Occasionally this side effect can happen with letrozole also. So we check the level. So what we do is we check the follicle, how many follicles first of all, and what is the size of the follicles. If the follicle is big and the endometrium is thick enough, and we are happy with the quality of the endometrium, then we can trigger the follicle with an HCG injection and then time the IUI either next day or 36 hours, depending on if it is weekend or also convenience of the patient, we can arrange it. The success rate is the same, whether you do it between 24 to 30 hours or at 36 hours. Because what you are doing by doing it earlier is you put the sperm inside, let the sperm wait there. We always make the men wait to meet. So similarly, we make the sperm wait here so that when the egg comes out, the sperm can go and fertilize the egg. And if you do it at 36 hours, if you are just putting the sperm inside at that time, doesn't take long for the sperm. The sperm is found in the tube within 2 minutes of putting it in the uterus. So it will go and catch the eggs very soon and fertilize the egg. And like I said, chances of success, we have put it very generously, 5 to 25%. Average is 10 to 15%. 5% is in women over the age of 40, 25% in women who is sort of under 25 years. So that's why the range is wider. Next slide, please, Delia. That is about IUI. I think we have covered all the points. Now, what is in vitro fertilization? So the second option I told you is IVF, in vitro fertilization. Here, what happens is we give hormone injections to the woman, and she takes it for approximately fortnight. During this period, she will have 3 or 4 regular scans. And after that, when the follicles are ready, we book her for egg collection, and we take the eggs out, prepare the eggs, and the sperm will be, donor sperm will be prepared in the laboratory, and both will be mixed in the laboratory where the sperm will fertilize the eggs. And next day, the embryologist will check for fertilization, and they will tell us how many eggs are fertilized. So here, we prepare the egg, we prepare the sperm, mix them. That is what it is. And IVF, has changed a lot over the years. My colleague Marion and Raj will support me in this. When we started our career, we were all transferring on the sort of in the same cycle. We never froze the embryos. We think, oh, frozen embryo has lower chance of success. No. We had to put it. We had to put it in day 2 or day 3 we were doing. Then slowly blastocyst culture came into sort of vogue, and then we started doing this. Because technology improves, we also change with the practice along with that, because we found that the blastocyst culture and blastocyst transfer gives us a better success rate, better implantation rate. So we started doing blastocyst. Then next stage or next step, we don't put it in the same cycle. Now we think frozen embryo has got a better chance of success. Frozen embryo gives a healthier baby. So we recommend couples to do frozen embryo transfer. Why is that? It is because when someone has stimulation, the ovaries are enlarged, there is abdominal bloating, their hormones are very high. This is not a situation. The body is not at all in the optimal state of health for implantation of the embryos. So they think that let the body recover and put the embryo in the next cycle, then it will implant better. So all of us now, we go for what is called freeze-all, and then we transfer the embryo in the next cycle. And we also have one more addition here. What it is especially women over the age of 35 or younger women with PCO, the egg quality may be sort of mixed. And here, because of this, there is chromosomally abnormal embryo in each person. Raj will tell us that in IVF, even in younger women under 35, 40% of the embryos are chromosomally abnormal. Please note that. That means nearly half of them are abnormal. If we don't test, we start putting the embryo one by one. And that's all waste of time, because if it's an abnormal embryo, you don't get pregnant, or you have a miscarriage or an abnormal baby. Why complicate life? You want to go home with a healthy baby, test the embryo, choose the best and the right embryo, that is chromosomally normal euploid embryo, and put it back inside. So you get pregnant in the first attempt and go home with a healthy baby. So this reduces the time to pregnancy and delivering a healthy baby. That is why nowadays we say freeze the embryos and then test the embryos and then put it in. Tomorrow, what will change, I don't know. This is so far is the up-to-date information. Next slide, please, Julia. So this is a simple slide, okay? All of us know what do we need to make a baby? Egg on one side, even a child will say these days, egg and the sperm, of course. This is to fertilize. And because in IVF, we don't need a place to fertilize, we are using the lab, that is fine. But at the end, we have to have a uterus, good uterus, so that when we put it back, the embryo implants. That's why they have written the normal uterus or absence of pathology. We see our clinic consists of all types of patients, Caucasian people, Asian, Afro-Caribbean, and everything. So our ultrasonographer says that, look, I have seen more pathology in your clinic than any other clinic. Yeah. Because we get a lot of people with multiple fibroids. So under these circumstances, we tell them, look, get those fibroids out. Otherwise, the baby cannot grow in this uterus. That's why, or any adenomyosis in the uterus, we can treat it, it is better. We want a uterus which is really good, because it's a good bed, only then the embryo can implant. Okay, next slide, please. So I think I already described to you, but I'll go through the details. I said that the woman would have hormonal stimulation, and we have very, very nice and friendly nurses like Marion, who will teach the injection. Marion is, of course, healthcare assistant now. She was a nurse before. And now they'll teach you how to do the injection. It just goes under the skin. It's subcutaneous. It's like the diabetic insulin injection. So you do it for something like 12 days. And during this period, you will be monitored with ultrasound scan and blood test, say 3 or 4 times. And then once you are ready at the end of the injection period, when the follicles are large, then we book you for an egg collection procedure, which is performed under anesthesia. When I say anesthesia, it is called intravenous sedation. It's not general anesthesia. It's not local. So general anesthesia has got its own risk. So we don't go to that. You don't need general anesthesia. Local can be painful, like going to a dentist, which we don't want to trouble you like that. I wouldn't do it for my family, so I won't do it to anybody else. So it's performed an intravenous sedation, and then we collect the eggs. It takes about 15 to 20 minutes to collect the eggs. We collect it through the vagina under the ultrasound guidance, so there is no cut involved on the tummy. And you will be allowed to rest for 1 to 1.5 hours. The nurses will monitor your observations, make sure you're recovering well, and then they will give you a nice cup of tea with biscuits once you are able to pass urine, you will be allowed to go home. One important thing is you must go home with someone. You can't go home on your own after the collection, because it's risky to go home on your own after anesthesia. Okay, so this is your side of the story. Then what happens in the lab? The eggs are prepared, sperm is prepared, donor sperm, and they are mixed in the Petri dish. And next day, Raj will go and check and tell me, so many have fertilized and some haven't fertilized. That is day 1. At that stage, embryo has got 1 cell. And then we keep following the embryos every day. Remember, every day the number will drop down. Supposing you start with 15 eggs, they are not, somebody told me, oh, there are 15 babies. What will I do? No, it is not 15 babies. Out of 15 eggs, you end up with 1 or 2 embryos one day in the end. So the number will drop. Some people get so upset about it. Oh my God, what have you done with the eggs? You took 15 eggs. We haven't done anything. That is the normal process. That is the way IVF works. So we culture up to the day 5 and 6. At that time, the embryo has got more than 100 cells. And we do the biopsy on that day. They will take 1 or 2 cells or few cells from the embryo. Another question everybody says is they are worried that, oh, you damaged the embryo. You are putting the needle into the embryo. No, we don't put the embryo in the needle into the inner cell mass. That is the baby part of the embryo. We take biopsy from the placental part, which is the outside one. Raj will explain to you in detail. We take it, and then After taking it, sending the cells to the genetic lab for testing, we freeze the embryos in our lab. And then meanwhile, you recover from this stimulation effect. Next month, we prepare your body and we know which embryo is the right one to give you the healthy way. Thank you. So, Delia, next slide, please. So now we are coming to the important slide. This is the success rate. And you can see that how simply freezing the embryo and also doing embryo testing, that is called pre-implantation genetic testing. A indicates aneuploid. That means any abnormality in the number. That's what it is. Down syndrome and all is an aneuploid. That is why we test for this. So when you have this IVF without PGTA and with PGTA, you can see the difference. With, the success rate is low, whereas here it increases tremendously with that. And of course, younger age, even without that, it is good. So it is about 45%. Whereas if you do the PGTA and embryo freezing, it becomes 55 to 60%. And as one gets older, as you can see, that the pregnancy rate drops. However, with PGTA, the pregnancy rate is much better, even in older women. Once you have one euploid embryo, you do very well because implantation rate is 50 to 60% with euploid embryos. Okay, so that's why it says, look, 60% success rate with this PGTA. And the beauty is that you get pregnant in the first attempt. Not like, negative pregnancy test or it is a miscarriage. We rarely have miscarriages in our clinic. We have miscarriage in those who haven't tested the embryos, basically. Next slide, please, Delia. Okay, so this is a debate, supposed to have a debate between Dr. Vastata and myself, whether IUI is better for you or IVF is better for you. I would say there is no right treatment or wrong treatment. You can't compare IUI with IVF. These are totally very different treatment. It's like comparing apple and orange. It's not at all the same. And so IUI may be the suitable option or best option for one couple, whereas IVF may be the most suitable option for another couple. It depends on their situation, age factor, their AMH, so many things are there. So we can't compare saying, oh, this is better and that is not better. It is, we have to say, what is the right treatment for yourself? That is more important than this. But if you compare the pros and cons of these two treatments, you can easily say the IUI is less invasive and less expensive. However, what happens is success rate is lower because they always say you get what you pay for. It is like that. So it's a simpler treatment. It's not that it's cheaper or anything. It is a very simple treatment. That's why there's not much work involved. Then why it is cheaper. But because we don't know so much about it, in the sense what's happening inside, the success rate is not very high. And if it is stimulated, we talked about multiple pregnancy. And it's a good option in mild infertility cases, but not when the sperm is not moving well, the sperm count is low, and this kind of things. We don't go for IUI. Even in donor sperm, if you see in some sperm banks, they will say this sperm is suitable only for ICSI. That means it's not good enough for IVF or good enough for IUI. The sperm has to be according to the WHO classification and good sperm. So if you have average sperm, then they will say, don't go for IUI treatment. And if you take IVF, of course, it's a more invasive, more expensive. And as I told you, much better chance of success, 60% live birth rate. And look at the cumulative rate over 3 attempts, 95%. That is beautiful. Nobody has got 100% yet, but over 3 cycles, you are definitely likely to get pregnant. That's the message we are trying to give you. And in our clinic, as I said, most of the women get pregnant in the first attempt if there is no other complication. Okay, and of course, risk of the multiple pregnancy is very much minimized here, because after freezing the embryo, after blastocyst culture and testing the embryo, we don't transfer to embryo unless some patients insist and they want to have twins, and they do it. But we still explain to them about the risk, and we say 1 baby at a time, 1 healthy baby at a time. That's our motto. That's what we do. And good option in nearly all situations. Even if everything is all right, say unexplained infertility, there is no problem. Even for same-sex couple, I told you initially, they are not infertile, and they has come to us for the sperm, and they brought donor sperm. So in their case, there is no problem. But even then, IVF definitely gives them a much better chance of success, 60% in the first attempt, and over three rounds, the cumulative pregnancy rate is 94%. So it is a better treatment, but I wouldn't say better than IUI. These are 2 different treatments. And see, I always say, if you want treatment on fast track, go for IVF. That will be quicker. You want to take your time and do it, go for IUI, do the natural method. It might take longer, you might achieve it, or even if you don't achieve it, you can always move on to IVF later. At least you feel that you have tried the simple and natural method. That's the way. But if people say, oh, I've been waiting for a long time, I can't wait, I want the baby now. In that case, go on fast track, go for IVF, get your baby and go. Next slide, please, Delia. Okay, now people phone us and say that, look, I've decided I want IVF. So when can I start? It is not like that. And we have to have a consultation with the doctor. The consultant will take a medical history. Then sometimes the patient tell us, oh, I had consultation in the other clinic, but I decided to not to have treatment with them because their care was not good. And that's why I changed the clinic. So since I've done the consultation, can I start the treatment? The consultation is to know about you, how to do your treatment, how to plan your treatment. That is why consultation is important. We need to know whether your uterus is okay without fibroids or any problems, and whether your ovaries have any endometriosis. Most importantly, how many eggs you have got. Based on that only, I have to plan the IVF, the protocol, and the dosage of the medication and everything. So without that, I cannot do anything. We also do a blood test to check the hormones, AMH. That will again give us information about the ovarian reserve. That's why it's important to do all this consultation and fertility checkup in the clinic where you are going to have IVF. So what we do in the fertility checkup is the pelvic ultrasound to assess the uterus and the ovaries, including the ovarian reserve. And the best time to do it is between the 2nd and 5th day of the period. And we also check the hormones, all these hormones which is mentioned. The key hormone is AMH that gives the ovarian reserve. However, even vitamin D levels are important. If vitamin D level is low, it can increase your risk of having a miscarriage. Similarly, if the thyroid is low, it can increase your risk of having a miscarriage. So we don't want you to go and have a miscarriage, come back and we start all the investigations at that time. It's too late. You should do everything beforehand, prepare you well so that you get pregnant in the first attempt. Next slide, please. Okay, now I can give rest to my vocal cords and hand over to Raj Joshi, who's an expert in the lab. We have been working together for such a long time, and he will tell you all the details of what is happening in the place where they make the baby.
Thank you, Dr. Venkat, and good evening, everyone. Just going to tell you about what we do in the lab. Basically, all donors in this country are identifiable, but they are only identifiable to the offspring once they turn 18. All users of donor sperm, they are only given non-identifying characteristics. And in this country, they're given a little bit more information about the donor's interest, and maybe the donor has written some information about themselves, and they'll may be able to read that information too. So the donor banks we use, we have the Harley Street Sperm Bank, which is our own. We have other UK sperm banks, the London Sperm Bank, Semovo, and there's overseas sperm banks. Now in America, and they have Zytex, which is one of the biggest, and it can give you a lot more information. It depends on how you pay, what tier of service you opt for. You can listen to the voice of the donor, you get donor essays, you can see pictures of the donors, you get a lot more information from the overseas sperm banks. The European Sperm Bank, I haven't had much experience with, but Cryos in Denmark I have. And again, it's, these all provide sperm, which is screened according to the HFEA requirements. Next slide, please. Okay, so the requirements to be a sperm donor, if 100 men are coming through to become a sperm donor, only 1 or 2 may be selected out of 100. That's how stringent it is. The donors have to be aged between 18 and 45. They must have no significant medical history. They are usually non-smokers. They have to be fit and healthy, between having a BMI between 20 and 30, and they have to have no personal or family history of an inheritable disease. There's also no history of mental illness in them or their family. And again, the sperm has to be good. Also, having good sperm parameters, so we're looking at the count, the motility, and the abnormality. Now, the World Health Organization says a count has to be more than 15 million. That's good. Anything more than 15 million is good. We also look at the motility, and the motility has to be above 42% for it to be normal. So anything above 42% is taken. And again, the abnormality, as stipulated by the World Health Organization, has to be 4% or above. And what we do is we stain the sperm and look at it very closely at the head, neck, and tail of the sperm to make sure everything is normal. And then again, they are tested for all infectious diseases, especially HIV, hepatitis B and C. Also, they are tested for STIs and STDs, and everything. As long as that is clear, they can start donating. Then they start giving samples and they donate. And then 3 months later, they are rechecked. Everything is rechecked for them. So if a sperm donor is donating, the process will take we need to get at least 60 samples. So this could be used for patients to try to get pregnant. And usually it's 1 or 2 ampules of sperm are used, depending on the volume. Next slide, please. Okay, how do you choose your sperm sample? Well, we prefer you choose unwashed sperm samples. And these are basically, it's the semen which hasn't been prepared. So the semen is mixed with something called cryoprotectant, and this actually protects the sperm while it's undergoing the freezing process. But however, the technique isn't perfected and we don't get 100% survival, if the motility is 50% when it was frozen, we'd be happy with a 35% motility on thaw, and that's what usually happens. So we'd ask you to buy unwashed samples. We will prepare them in the lab. We will ask you to order at least 2 ampules, just in case the first ampule thaws poorly, in that we don't get good survival. And this doesn't always happen, but sometimes, you know, we find that it's not adequate. And then what we can do is speak to the sperm bank, and you can speak to the sperm bank, and we may be able to negotiate another ampule from them of that donor if you wish. And how we prepare the sperm in the lab is, again, we'll thaw out the sperm. We just take it out from a storage container, which is in liquid nitrogen. The vial of sperm is witnessed going in by 2 people into that tank. It's labeled with the patient's name, the patient who's going to use it. It's labeled with the patient's name and number and the date it was came into the clinic, and it's stored. So it's witnessed by 2 people. When we take it out, it's witnessed again by 2 people, and it's assigned to you electronically, because we have the RI witnessing system, because everything under the microscope looks the same. The eggs and the sperm, everything for everyone looks the same. We're not that different after all. So basically what happens is everything is witnessed, everything is labeled electronically. We assign that sperm to you, and we assign that sperm to you, and then we start preparing it. And this is prepared using fine silica beads in suspension over a density gradient, and this is spun in a centrifuge. Now, the sperm, the fastest motile sperm, will be drawn to the bottom of that tube as it's spinning, and then we will wash that sperm twice, and then that is what's given to the doctor to inseminate you or use for IVF. We would actually say, please choose sperm that is suitable for IUI or ICI, and if you are fortunate to get pregnant, please consider reserving further samples for siblings. That's the case if you're having IUI. If you're having IVF, hopefully you will have surplus embryos frozen, which you could use for sibling samples as well. Same-sex couples can also actually have, both of them can use the same donor to maintain a genetic link, and then implant each other's embryos into each other to, further maintain a kind of like a genetic link, as it were. But again, because all treatment in this country is regulated by the Human Fertilization and Embryology Authority, the HSFC, special forms need to be completed if you're going to be using the same donor and implanting each other's embryos into one another. Next slide, please. Choosing a donor, how do you pick? What do you do? So, basically I would look at the donor banks in the UK, have a look at everything that's available. The HFEA has a lot of supportive information, which it can help you decide how to pick a donor. We would say pick a donor that has proven fertility, meaning they've fathered children, they have their own children, or they have pregnancies from other centers, and the donor bank will be able to tell you that. And this is helpful because, it shows basically you have a better chance of getting pregnant if you use a proven fertile donor. Be flexible, because if the treatment is successful and you do have a healthy baby, you need to let us know so we could let the donor bank know, because these slots, each donor is allowed 10 pregnancy slots. So around about 5 slots, and if patients have the 5 patients have embryos frozen, then the other slots will close. So that donor, we're just making sure that the donor doesn't reach its 10 pregnancy limit or go over, because the HFA are very strict in this. I have put some more information here. The HFA have a code of practice that we follow. There is this link here, and the section you need to read, basically for more information, is section 11, page 118 to 133, which is the donor recruitment, assessment and screening, which will give you a more in-depth analysis of what, the HFA ask us to look at, and what donors need for their assessment and screening. Next slide, please. Donor anonymity. Children born from donation have the right to learn the identity of their donor when they turn 18. Unfortunately, the people who use donor sperm cannot know the identity unless they can only know non-identifying information, and information as such that donor has written on their donor form. The children, once they turn 18, they can request information from the HFEA, and children born from donation may also request identifying information about donors, donor-conceived genetic siblings with mutual consent from the age of 18. However, it is up to the parents to inform the child first. Not every couple wants their child to know. So, it's entirely up to the parents how they go about this. We, as a clinic, advocate openness and transparency, as this demonstrates, there's been a lot of research done on the donor children, and having openness and transparency, this will basically have better family outcomes, and you've got a better understanding as a family, and more a support system there should you require it. Next slide, please. Okay, legal parenthood. Donors are not the legal parents. They basically relinquish all rights and responsibilities at the time of donation. And this is from the Human Fertilization and Embryology Act 1990. So donors are not the legal parents. You as a couple are the legal parents. Okay, next slide, please. Okay, Marion, over to you.
Thanks, Raj. My battery is running low, so I'm going to have to be pretty quick. Can I have next slide, please, Delia? Hi, Delia.
I'm here, Marion.
Oh, thank you. Sorry, that's fine. Thank you.
Of counseling. Yes.
Yeah, we addressed all the concerns that the patients may have, and we also would recommend that they think about other issues that may not have come to them to think about. So what you try and do we're doing counselling, which is implications counselling. That's done by a trained counsellor. You have a session with them, and if you need further information, they can give you that as well. We just want to make sure that you understand exactly what using donor sperm, particularly for these patients, involves, and also that they understand some of the the things that can happen later in life and that you may need to consider. And we provide you the opportunity to have non-clinical questions answered. Next slide, please. The role of the fertility nurse, which is close to my heart, is being there for the patients. We want to support them through this journey and make it as easy for them as possible. Any questions they have, any concerns they have, we're always there for them. If they want to phone us and talk to us, come in and see us, and during their treatment, we're always there for you. All the nurses are able to sit with you. And if you have specific things you want to talk about, we'll be there for you. Next slide, please.
Now we have our wonderful Nikoleta and Karleen, who will talk about their journey with Luca in the background.
Believe it or not, literally just now, Luca is a very angry bunny. He just had to go have his bath because he was getting upset. So Karleen's taken him because he usually has his bath time around 6:30, and he's realized he hasn't had it. So he wouldn't have been good company on this call. So it's just going to be me for now. Unless Karleen is able to bathe him and get him back out, but I don't think she will. So hi guys, I'm Nikoleta. My partner Karleen and I used Harley Street Fertility to conceive our first baby, baby Luca. And I just wanted to spend a few minutes just giving you guys a bit of insight on how we found Harley Street, kind of how we interacted with the doctors and the staff, and just kind of the treatment that we went with. So I'm a bit of I overanalyze everything. So when it came to picking a fertility clinic, especially as an older mother, because I was 35 at the time when I started, I'm 37 now. We really wanted to make sure that we had the very best clinic, and we don't live in London anymore. So we moved out of London about an hour away a year before we started this journey. And essentially Harley Street, there were so many clinics in London, but Harley Street was the requirements we were looking for, which were really high success rates, visibility into their procedures and what they offered, and they had so many different treatments. So we knew if there was any types of issues that they'd be able to kind of find a plan for us. And also being a same-sex couple, we kind of really liked that it was mostly, you know, there are some male nurses, but it was a mostly female staff, especially with the consultants. So that was really for us some of the main points on why we chose Harley Street. Dr. Venkat was fantastic throughout the entire process. We met with her initially for one of our initial consultations. I remember this was back in December, right before the UK left the EU. And at the time we had used cryos to get our sperm, and we had reserved it. It was still just sitting in Denmark. And she, you know, explained to us, it's important for you to get it shipped over because, you know, of the rules and stuff we didn't even think about. So right away, we just felt quite drawn to her because she was always quite friendly and answered all our questions in a very empathetic way, just genuinely passionate about, you know, what she does. And we know she has thousands of clients, but we felt quite, you know, quite special. Baby's out of that. And most of my treatments in the clinic when I would go were with Dr. Verstraete, and she was really great, explaining the procedures to me before she did them. I mean, they get quite personal, for obvious reasons. But I have to say, you know, both Dr. Venkat and Dr. Verstraete were fantastic from start to finish, and we always felt very informed, always, you know, told what was going to happen next. It was never a surprise. And everyone was very attentive. Now I know they went through the treatments. We decided to go with IVF for a lot of the reasons that Dr. Venkat kind of described. It had a much higher success rate. I had to get my eggs harvested. We had the donor sperm, and essentially that was the best process for us, just because we really didn't want to go through several rounds of IUI, especially because I was 35 at the time, and we knew, based on the statistics on the Harley Street website, the longer you wait, the less viability of the egg. So we just decided to go straight for the IVF, and it was a great choice because leading to the next slide, we got pregnant on the first try. And we know a lot of that has to do with the different treatments and medications that Harley Street prescribes for us specifically. Because I know, speaking to other people that had IVF treatments at other clinics, they didn't have the same plan that we did. And I think that contributed to why I had such a high success in the number of eggs collected and the number of embryos that were created that were of high quality. And, you know, we had them tested as well genetically, not all of them, because I had 13 to test, would have been very expensive, but yeah, we were very pleased, and it resulted in the birth of our son, Luca, who you might hear screaming in the background at some point, but yeah, baby Luca was born this year. He was born in February, and he is such a lovely baby. We couldn't be happier, although I think they downplay how hard it is with sleep deprivation. Delia knows, I've talked to her about it, but we are so thrilled to have him. And we know if we didn't have Harley Street, it wouldn't have been such a smooth and kind of seamless process. I'm sure the story is not the same for everyone, but for us, it's been fantastic from start to finish. And we're very happy to have Luca in our lives. He might make a cameo. I don't know how quickly my partner will get him dressed. I'm all stressed. He's got his little night suit on, but he'll come out and say hello before we close off. But that's our story.
Thank you, Nikoleta and Karleen. We have some frequently asked questions. Will a donor be held responsible if the child is disabled? Yes, if they were aware of the disease and failed to disclose it. Can donors change their mind? A donor may withdraw or vary their consent at any time until the embryo is transferred. How many times can a person donate? 10 family clinic. Our clinic limit is 6 families. What do they find out about their donation? Outcome, number of children born, sex and year of birth. Can a donor be paid? No. Compensated £35 per visit. Do you have lots of donors? We are growing our donor bank. Yes, and baby Luca is in the background. You'll find this webinar is recorded, so you'll find further resources with some very useful links. Practical steps. IUI is a great treatment option for same-sex couples and single women. Donor sperm allows single women, same-sex couples to have children. So it's time to start the journey, arrange a consultation with our wonderful team, and talk to us. We are here to help. And baby Luca is adorable. We have to say.
Oh, so lovely, so lovely.
Bedtime, past his bedtime?
We are pushing his bedtime later and later because he keeps waking up at 5 in the morning.
Okay.
So
maybe this is a trick. Webinar. He should attend webinars.
yes.
Yes,
So
yes,
he'll
yes.
sleep through the night. I'd like to thank everyone, all our wonderful panelists tonight. And we have only one question or a statement from Alex, whom I promised I will send him a webinar link for our previous male fertility webinar. He says the problem is 80% of sperm donations to fertility clinics is rejected because unsuitable for freezing. This leaves most gay men wanting to donate to approach couples. So what do you think? Raj, would you like to answer this? Statement?
Yes, like I said, it is very stringent because you can have a really good count and good motility, but not all sperm will freeze in the same way. And we always do a test thaw when we freeze, and thaw some of that sample, a little minute amount, just to count and see how well the survival is, to give us an idea. And sometimes it does not thaw adequately. We want at least, if a sample is 50% motile when we freeze, we want at least 30% motility on the post-thaw. Or, we'd be happy with around 25 to 30, but 30 plus would be ideal. And not all samples, unfortunately, freeze. This is why if 100 men are coming to donate their sperm, only 1 or 2 will be taken on as donors, because all of the others will have something wrong, something a genetically a family genetic disorder or disease, which, you know, we can't take them on. And if I think I understand where this guy is coming from, and his he wants to donate, but I mean, all I can recommend is that you have to be very careful, because recently in the media there was someone who donated and had said in the fine print on his website that he was suffering from a genetic disorder. Unfortunately, not everyone read that who used it. And subsequently, babies were born with the same genetic disorder. So it is frightening. Please go to a reputable clinic, because the clinics have to abide by the Human Fertilization and Embryology Authority regulations. So please, please, please be careful.
Thank you, Raj. We have 2 more questions. Are you able to transfer egg from one partner to another?
Dr. Venkat?
Yeah, so actually this part of it's a good question. I actually did not mention about this. I think it's high time we mentioned about it, because for same-sex couples, I always say there are 2 women with eggs there in that relationship, and there are lots of options for them. They are lucky. And by the way, I would like to thank Nikoleta and Karleen for bringing the little beautiful Luca.
It's gorgeous, isn't it?
Yes, gorgeous baby Luca, and narrating the story so truthfully that all you said was the truth, and your experience is really touching the heart. But I can't promise that all the babies will be so beautiful.
And well behaved. Dr. Venkat, we only have beautiful babies at Harley.
Beautiful babies. And
only
also
beautiful babies.
Beautiful babies and well-behaved babies.
Yes,
because all of them
course.
come back and say that, oh, sleeps throughout night. What a wonderful this thing, isn't it? But anyway, coming to the subject, you are right. There are now, it's called intra-partner donation or shared parenthood, because both have eggs, both have uterus, and they want to sort of get involved in this child. Both of them want to get involved, which they can do. And so one person gives the eggs and the other person uses the uterus so that she carries the baby. And so what happens, this woman A gives the eggs, and we fertilize with donor sperm and put it inside the other woman's B's uterus. So that is called partner sharing, shared parenthood or intra-partner donation. And there is one more I can add to make it better for the couples, because if we add egg shared with that, they can also have free treatment. Don't forget, as I told you, IVF is more expensive. And if the woman is under 35, I keep mentioning they are not infertile people. They come to the clinic to get some donor sperm. And if they are willing, if they do not mind sharing their eggs, so when the patient A goes to the egg collection, we give half the eggs to the couple and the other half, 50%, is donated to somebody else. But before they do that, that person has to have all the steps for being an egg donor. Like the way Raj described, the egg donors have to have all the screening tests like infectious diseases, chromosomes, and genes, and also they have counseling to make sure they understand the full implications. And we also write to the GP to make sure there is nothing in their medical history which can contraindicate. So they do extensive testing, and then they do what is called egg sharing. So if one partner does use her eggs and she donates half the eggs and donates the other 50% is fertilized with the donor sperm, and the created embryo is transferred into the other partner. So this is called intra-partner donation as well as egg sharing. So the treatment is very much discounted. So it's a mutual benefit. They are helping somebody because they are benefiting. All the same-sex couple tell me this. We are benefiting from some donor donating the sperm. So why don't we give back something to the community? So we give our eggs to somebody. And they also benefit in return financially. There is a discounted treatment for them. So that is something I wanted to mention in IVF. It is very important. And some couples come and reverse the role later also. The other person uses the egg, and then this person carries the baby. Usually how they select is they go for the older woman to do it first, so that the younger woman then uses her eggs later on. That's why it's called intra-partner donation or shared parenthood. And if they donate it to others also, other patients, then it becomes egg sharing as well. So this is the combination here, which works very well. We have done it in our clinic. Marion has worked with me. We got a lot of donors from Kent, and many of them did this. And both the parties had their babies in the first attempt. And that is not only the couple, and also the recipient of the couple's eggs also got babies in the first attempt, which is wonderful. You know, it's so lovely to see so many people becoming happy with this. And it's a nice arrangement. And there is, of course, if people have any concern, we ask them to have counseling first so that they understand the full implications before they embark on any treatment. I think that is a very nice arrangement. So, Karleen, let's have a look at Luca then.
Oh, he's in bed.
He's in bed.
He's now
He's in bed now. Okay.
Sorry.
So,
we brought him, he came out after his bath. You must have not you may have not had us on your screen, but he came out after his bath for a little bit.
Yeah, so he's well behaved.
He was very, very tired.
Good, good.
We have another question. What is the age limit for egg transfer, and what would the process include? I think you covered, Dr. Venkat, the second question. So the first one, what is the age limit for egg transfer?
Sorry, age limit? What is the question?
For the egg transfer, the age limit, or embryo transfer, I suppose. The age limit for egg transfer?
Well, a transfer means if somebody it is donating to the partner, then it is, there is no limit. It is fine because it is within them. But whereas if they are donating to somebody else, and then it is under 35 years. And age limit for embryo transfer, if you look at it in general, we say in our clinic, we use the guidelines of up to 50 years. That means up to 51st birthday, we can transfer embryos into a woman. But over that age, we go by the individual merits of the case. It's not like we don't have a blanket policy saying we don't treat anybody after that. If anybody wants, then we look at the individual characteristics to make sure there are no contraindications, there are no medical complications, and the welfare of the baby. That is the most important thing. We make sure the baby is not going to suffer in this world. So we look into all the considerations, and we have ethics committee. We discuss in the ethics committee, and then we make decisions. I suppose I answered your question. I didn't get the real meaning of the question.
Thank you. We have another question. What is the success rate for IVF over 35? I have to say this webinar is recorded, and there was a slide with the success rate. You will find all the information in the recorded webinar.
But success rate depends on what you do and where you do and which lab and the experience. Like we said, if you transfer embryos, say without any PGTA, testing the embryo over the age of 35, the pregnancy rate goes down compared to 35 and under 35. Whereas if you do PGTA, the success rate is much better. because
Yes.
euploid embryos implant better. The implantation rate and success rate is coming up to 40–50%. And even in women over the age of 40 and 42, we find that it improves the success rate, provided we have euploid embryos.
Thank you.
But for this, for example, I can quote a case of a woman. I very much remember because she was 48 years and she said she got married late and she wanted to have IVF. And I was really, my heart sank. My God, how can I make her pregnant? She's 48. When we did all the fertility checkup, I was surprised. Her AMH was 28. And you won't believe, I was really pleasantly surprised, I should say. And then I told the woman, look, if you are willing to give it a go, I am happy to try it. But don't have a lot of hopes. It depends on how the quality of the eggs are. And for her age, she did extremely well. We collected 22 eggs from a 48-year-old woman, which is unbelievable. And then we got 8 embryos in the end. And we tested all the 8 embryos. You won't believe she had only 1 chromosomally normal embryo. But at least she had 1, because many of our patients at that age, they usually have all chromosomally abnormal embryos. Raj is nodding his head, which is true. Whereas this woman was lucky, she had 1 chromosomally normal embryo, and we transferred it in the next cycle. And she was telling me, oh, you have only 1, doctor. I want to have 2 embryos. I said, look, we have only embryo. Let's put it in and see what happens. And we put it in, and she has a baby now. She has a little girl at the age of 48. In the first attempt of IVF, she got pregnant. That is because we did PGTA and put the right embryo back inside. And she was lucky to get pregnant and have a baby at that age. It was a miracle baby. But she's so naive and simple. She doesn't understand how lucky she is. It's just sad. Yes.
Thank you. Thank you, Dr. Venkat. Thank you, Raj.
Thank you.
Thank you, Marion. Thank you, Nikoleta and Karleen. To wrap up this wonderful webinar, we are here to help. We have an absolutely amazing team, starting from the front of house, the reception, a wonderful nursing team, and to not say Dr. Venkat, the best embryology team and nursing team, including Marion, or especially Marion. Please come and talk to us. We are looking forward to welcome you to our family. And don't forget to register for our webinar, Fertility Initiative. And thank you to everyone.